Today's topic is things to think about when choosing a chronic lymphocytic leukemia treatment. And we're going to be joined by Dr. Joanna Rhodes. We chose this topic because treatments aren't one size fits all. What works best for someone might not be the right fit for you. And we've invited Dr. Rhodes to share and really help educate us about this topic. This will be recorded, so you'll have access to this after the event as well. So I'm going to introduce Dr. Joanna Rhodes now. Dr. Rhodes is the director of the lymphoma program at Rutgers Cancer Institute, systems lead for lymphoma for RWJ Barnabas, and an assistant professor at the Rutgers, New Jersey Medical School. She completed her medical degree at Stony Brook University School of Medicine and went on to complete a residency in internal medicine at New York Presbyterian Weill Cornell. She did her fellowship at the University of Pennsylvania and also received a Master's of Science in Clinical Epidemiology. She is board certified in internal medicine, hematology, and medical oncology. Her clinical interests are chronic lymphocytic leukemia and other lymphomas. Her research interests include the development of novel therapies for CLL and lymphomas, as well as pharmacoepidemiology of targeted agents and lymphoma and toxicology management strategies. And with that, I'm going to turn it over to you, Dr. Rhodes.
Thank you so much for that introduction, Dalton, and thank you everyone for joining us live on a Wednesday afternoon and sharing your time with us. So I'm going to, oh boy, share my screen, I hope. I think I can't share, and I'm sorry. I should have done this earlier. But in the meantime, we can start. So obviously choosing a CLL treatment is a personalized decision. I think the most important thing when I talk to patients about frontline treatment in my clinic is that everything is actually very good. We have lots of amazing treatment options now, whether it's clinical trials or standard of care treatments. So we'll talk a little bit about what our standard of care treatments are and sort of level set as to sort of what needs to be done prior to even starting treatment and ensuring everybody understands what CLL is and why we treat things the way that we do. I'm going to try again.
You can try to remove you as co-host and then add you again and see if that'll help trick it into Litnia.
That would be great. Sorry, everyone.
It's okay. Technology is fickle.
No.
You don't see the green share down at the bottom.
No, I do. It's just when I open it, it says access is denied. It's got like a big, it's got a, why don't I try leaving and coming back in?
Okay. We'll be here for you. All right. So Dr. Rhodes will be back with us in a minute. Hopefully we're able to get this figured out. Now I can also see if she can send me her slides and then I can just share them for her. So stick with us, guys, and we'll get this figured out. If not, in speaking with Dr. Rhodes, she's a fantastic speaker, so I'm sure that we'll all get something out of this regardless of their slides or not.
Still not working.
Let's see. Try one more time. If not, you can, if you're able to send me your slides, I'm happy to share them for you.
Okay.
And then I can just play the assistant and click through for you.
Let's do that. Sent.
Let me check here. Technology is wonderful, except for when it's not. Now my email's being slow. So there we go.
Got it.
Perfect.
Sorry, everyone. All right, so now getting to the meat of things. So I wanted to talk, we're going to talk a little bit about considerations for choosing frontline CLL treatment. These are just my disclosures. So I always like to level set when I start a talk about any type of CLL talk or lymphoma talk, just to make sure that everybody's sort of on the same page. Really make sure that, because everybody is in a different stage in their CLL diagnosis and journey, and I always want to make sure that everybody feels like they've heard and are on the same page from sort of the learning about the basics of CLL. For some of you, this may be like the 40th time you've heard this. For some, it may be new. So I just want to make sure that we're all sort of educating ourselves together. So the epidemiology of CLL is always changing. We see that the majority of patients are diagnosed sort of in the later half of life. 65 and over makes up the majority of our patients with a median age of diagnosis of 70. We know it's also the most common leukemia in the Western Hemisphere and makes up about 25% of leukemia diagnoses. It's more common in men, more common in Caucasians, and about a third of patients never need treatment. So what exactly is a diagnosis of CLL? How do we get to that? So CLL, we have sort of three things that I think about that are sort of CLL or CLL adjacent. Monoclonal B lymphocytosis is often the precursor to CLL. Basically, you have the same phenotype of CLL lymphocytes in your bloodstream, but without any lymphadenopathy and the number of lymphocytes is actually lower. This is probably a very under-recognized condition for many people because you do need to actually have done flow cytometry in order to find it, and often that requires somebody noticing that your lymphocyte count is elevated. And there's about a 1 to 2% chance of progression to CLL each year. And it probably does make up 2.5 to 5% of the population may actually have this, is sort of the estimates. When we get to CLL, we know that patients have a very specific phenotype of these abnormal B cells in their bloodstream, and the diagnosis requires having more than 5,000 monoclonal B cells circulating over at least 6-month period of time. A lot of times patients with CLL are not symptomatic at the time of diagnosis, and it's very common to come into our offices and just have had some abnormalities on blood work that was done, say, as part of routine healthcare, an insurance assessment, going for preoperative testing for some sort of joint replacement. All of these can happen very frequently. And finally, SLL is the same thing as CLL, but instead of seeing a lot of cells in the blood and sort of the more leukemic version of this, we're really seeing more lymphadenopathy, more enlarged lymph nodes. But again, it's the same phenotype that we're seeing of these abnormal cells. And so what are these abnormal cells? So we often call them smudge cells when we look at them underneath the microscope. These are all CLL cells that they're very fragile. And so when we smear the blood in order to be able to look at it underneath the microscope, those cells are delicate and they actually will break. The sort of classic flow cytometry phenotype, we often talk about CD5 positive, CD10 negative, and CD23 positive. If you've ever looked at your own flow cytometry or have those results, that's part of sort of the classic version, the classic phenotype that we often see for CLL. And so I always like to talk about this because I think it's important when we talk about initiating treatment to ensure that all the correct prerequisite tests are done prior to initiating treatment, because it may not change things right up front from a diagnostic standpoint, but I do think it does matter when we think about treatment, about what either you're going to choose for treatment or about how we think that you will do a treatment or the length of time that you'll get, let's say, on a particular treatment. So we always do blood counts and an exam. A bone marrow can be done, although it does not have to be done all the time. Sometimes there's a reason to do one. Oftentimes, if there's something that comes up sort of abruptly, let's say a large change in a blood count that I don't know is necessarily related to CLL, sometimes I will do a bone marrow biopsy just because other things can happen in the bone marrow that may not just be progression of CLL. Again, immunophenotyping and doing flow cytometry is super important, again, because we just want to make sure we know exactly what the correct disease is that we're treating from the start. Quantitative immunoglobulins are important. So we all have immunoglobulins, which are antibodies floating around in our blood that are there to protect us against infection. Over time, as CLL progresses, patients can have what's called hypogammaglobulinemia or a low IgG level. I think it's important to know that, especially prior to starting to treatment, because that can put you at risk for infections, and we may want to do extra prophylaxis, extra medications to prevent infections in that scenario. Sometimes we will give supplemental IVIG, so give you other people's immunoglobulins to sort of protect you from the usual infections, things like colds, viruses, flus, pneumonias, things like that. FISH testing should also be done, whether or not it's at diagnosis, but then also repeated right before starting treatment. The reason being is that if there's a lot of time between when the time you were initially diagnosed to when you start treatment, things can change over time. And we always like to know what the genetics are of your CLL because it does tell us how you may respond to treatment. Karyotyping is when we look at all of the chromosomes specifically underneath the microscope to look to see if there are any large changes. And again, this is another test that can be helpful for what we call prognostication, understanding how your CLL might behave. DNA sequencing takes into account that there are some mutations that CLL can develop over time, some of which can respond differently to different types of treatments. And so again, sort of understanding what the genetics of your CLL are before starting treatment, I think is important. It can actually impact how we either decide on treatment together or how we think treatment will work for you. And as part of all of our staging systems, beta-2 microglobulin tells us really how active your CLL is, and same with LDH. LDH is a marker for cell turnover, and so sometimes we can see that it's elevated over time as CLL becomes more progressive. Also important because if it's very high, we have to look for other causes of that since it's not typical to have a very, very, very high LDH with CLL. Additionally, we always want our patients to have hepatitis B testing done because many of our drugs can be associated with hepatitis B reactivation, and that can be something that has no clinical significance. We see maybe some changes in your liver function tests, but it can actually lead to liver failure and death. And so knowing what your hepatitis B status is and if you need prophylaxis to prevent that from happening is very important. So again, the major thing that we're looking for when we do FISH testing is looking for something called the deletion 17p. Again, especially in the chemoimmunotherapy era, we know that those patients that have this didn't respond very well to chemoimmunotherapy. They do respond better. These CLL cells do respond better to some of our newer treatments, but the durations of response may not be the same. And I think it's important to know that going into treatment. And again, looking for TP53 mutation specifically by mutation analysis and gene sequencing, again, is also important. Again, for the same reason, TP53 actually lives on chromosome 17. So knowing if that's there is important, as we know that if your CLL has that mutation, you may not respond to treatment for as long as somebody whose CLL doesn't. Now, that doesn't mean treatment won't work. It just means it might be a little bit of a different time period till the next treatment. And additionally, mutations of the immunoglobulin gene. So you may have spoken with your doctor about whether or not you're IGHV mutated or not. I do think is also important to know at the start of treatment. As we know, CLL that is IGHV mutated responds very well or favorably to many, many treatments. And this is the old data that sort of shows exactly what I said before. This was with chemotherapy, and again, we don't use this regimen very often anymore, if at all, and particularly not for most patients, because as we can see, the time for patients whose CLL has a deletion 17p to progress is actually quite short in comparison to some of our other treatments. So for patients whose CLL has a deletion 17p, chemotherapy is not the correct thing to do in the frontline setting. And I will argue that I don't think it's correct for almost anybody at this point. And similarly, we see that having a CLL that is IGHV mutated, which is this line up here, again, with chemoimmunotherapy, has a very favorable response, less so for CLL that's unmutated. But again, I think that these are markers that are important to know, because now we know that our drugs are a little bit better than chemoimmunotherapy. But knowing this information, I think also gives us a better idea of how your CLL might respond. So what are the symptoms of CLL? A lot of these are the things that will lead us to decide that it's time to start treatment. Fatigue, shortness of breath, you can have enlarged lymph nodes or an enlarged spleen. Enlarged spleen can lead to weight loss because the spleen, when it's big, it's taking up real estate in your abdomen, and so your stomach gets very full quickly because it can't expand the way it normally would. Patients can get infections as their CLL progresses, as well as night sweats. But for some patients, when you're initially diagnosed, you may not have any symptoms at all and can maybe go on to develop some of these over time. And again, when patients are initially diagnosed, we often talk about the fact that there's this active surveillance portion of CLL treatment and I look at it as part of CLL, the CLL journey and CLL treatment in of itself, as active surveillance allows us to ensure that you have your CLL team in place, you have all of your vaccinations done in order to prevent any infections, as well as ensuring that you're staying up to date on your routine healthcare maintenance to prevent other kinds of cancers. The majority of patients with CLL will eventually need treatment during their lifetime. How many lines of treatment still remains up for debate, as our treatment options have changed and sort of the entire treatment landscape of CLL has really evolved over the last 10 to 15 years. But about a third of patients often will never need treatment. So our indications to start treatment are disease symptoms. Patients can have fatigue, night sweats, weight loss. And the fatigue often can be the thing that affects quality of life. And in my experience, it's always the hardest thing to sort of tease out how much of that is CLL and how much is that we're running around in a society that really does make us work a lot and has a high stress level. Low blood counts, so whether or not your platelets are less than 100,000, your hemoglobin's less than 11, whether or not you have any refractory autoimmune complications. So some patients can develop autoimmune hemolytic anemia. They can develop low platelets related to an autoimmune cause that maybe isn't responding to our usual therapies. And depending on bulky disease, whether or not your lymph nodes are enlarged and are very big or are causing pain or symptomatic. If your spleen is symptomatic, some people can have a very large spleen. I think the largest one I've ever felt personally was around 30 centimeters, normal is around 10. And whether or not your white blood cell count is doubling very rapidly. There's no actual magic white blood cell thresholds for us to actually start treatment. And so that's another thing to always discuss with your doctor, is sort of what's the cadence of my white count going up. Because I've had patients that have walked around feeling very well with a white count of 300 to 400,000 and haven't required treatment at that time. But I know that that's a number that's quite scary, both to patients as well as to other providers you may see for other parts of your medical care. And so I like to show this because this really tells us a lot about the story of CLL and our treatments over time. Initially we really only had chemotherapy. Once the Iron Curtain fell, we got a drug called bendamustine, which is a nitrogen mustard, which has been very important for lymphoma treatment. And then in the 2000s is when monoclonal antibodies against a marker called CD20, which is expressed on CLL cells as well as other lymphomas, got FDA approval and really has sort of changed the treatment landscape for so many patients with B-cell malignancies. We now have and rituximab was the first one. Now we have obinutuzumab, which is such an integral part of our frontline treatment options. And then sort of over the last 10 years is when we've seen the approval of all of our targeted agents, which I think is so important. Initially starting off with the approval of ibrutinib and then venetoclax. We have the approval of the PI3 kinase inhibitors, many of which are used a little bit less frequently, but are still available. And then in 2019, beginning in 2019, we got our second generation BTK inhibitors, first with acalabrutinib, and then following with zanubrutinib in 2023. And combination fixed duration treatment with venetoclax obinutuzumab was FDA approved in June of 2019. It was a very exciting approval for our patients who wanted sort of a fixed duration treatment, but didn't want to, and who we knew that chemoimmunotherapy was probably not great for. And finally, now we have the approval for new drugs and greater than the second line setting. So after patients have had a BTK inhibitor and a BCL2 inhibitor like venetoclax, most recently pirtobrutinib, and then this year we actually got CAR T-cell therapy. So really the treatment landscape for CLL is ever evolving, as you can see, particularly in the last 10 years. And oftentimes when I talk to patients, I don't know what the next iteration of treatments will look like. And so it's very hard to say what your treatment will look like until you actually need it, because our guidelines really change every 6 to 12 months, which is super exciting and I think wonderful for patients. You get to kind of bet on the future of research. So how do all of our drugs work? So most of our drugs are actually, sorry about that. Most of our drugs often work through the B cell receptor. This is a receptor that that is constitutively activated in CLL cells and really tells them to continue to make new cells, but also as part of how all these CLL cells stick together. So ibrutinib, acalabrutinib, and zanubrutinib all bind to BTK here, which is just downstream, one of the effectors of when the B cell receptor is activated, and blocks all of this signaling down here, preventing all of those signals from happening, which allows the CLL cells to sort of release from each other, go into the bloodstream, and die off. Obinutuzumab is an anti-CD20 monoclonal antibody. And so basically what it does is it binds to the surface of our CLL cells and then creates signals that activate our immune systems in order to kill off those CLL cells. That's actually why you often have infusion reactions, is you're really activating the immune system quite robustly. And finally, venetoclax is a BCL2 inhibitor. BCL2 is basically what we call you'll see the words anti-apoptotic. Apoptosis means cell death. And so all of our cells are, after a specific amount of time, basically they get old and they're supposed to die off. These CLL cells overexpress BCL2, which is basically a don't die signal. So this is one of those signals that can make cells live longer than they're supposed to. And venetoclax basically can block that, allowing cells that shouldn't be around to die off. So it's been and it's very potent. So these are sort of the backbone of our frontline treatment for CLL. So really what we're going to talk about today is, if you have treatment-naive CLL, how do you decide between our current treatment paradigms? We have two right now. We have continuous therapy, and then we have fixed duration therapy. And in reality, we don't have head-to-head data that tells us that one is better than the other. And so it's important for all patients. I think the most important thing for patients to know is that your preference to what you would like to be treated with, I think, is really one of the most important things. But having this is often a very long discussion with your doctor about the pros and cons of each treatment option and how that fits into your life, your own life specifically. So in terms of potential frontline treatment options for CLL, for continuous treatment, the current FDA-approved agents are acalabrutinib with or without obinutuzumab, zanubrutinib, ibrutinib with or without obinutuzumab, although I think we're using ibrutinib less frequently. And for fixed duration treatment, meaning that you're going to do treatment for a certain amount of time and then stop and be monitored off of treatment, we have the combination of venetoclax obinutuzumab in the frontline setting. So I just listed off 3 different BTK inhibitors. So how do we decide between the 3 of them? So this is this is a very specific diagram looking at where the red dots are is where the drugs bind to and inhibit a protein. So what we're looking to see is that what we can see here is, right, this is ibrutinib. So we're looking for what we want to see is, you know, red dots here for where the tyrosine kinase is, that the Bruton's tyrosine kinase is. But we can see that there's a lot of red dots not just in that area. And we think that the inhibition of some of these other kinases is probably what leads to some of the side effects. We can see that zanubrutinib also has some off-target side effects, acalabrutinib a little bit less so. And we know that our 2nd generation covalent BTK inhibitors have a higher specificity for BTK than our 1st generation. So first we'll talk a little bit about acalabrutinib. So we know in the frontline setting that we have great outcomes with acalabrutinib, whether it's combined with obinutuzumab, which is this green line here, or whether or not it's as a single agent, just as an oral pill with this purplish line here. These were compared to a drug called chlorambucil in combination with obinutuzumab. Chlorambucil was one of the chemotherapy pill that was used pretty frequently in CLL. It had good efficacy, but clearly not as good. So when we look sort of at 72 months or almost 6 years, we're seeing that fewer patients have progression of their CLL, had their CLL, you know, progress while on treatment with acalabrutinib compared to patients that had previously been treated with chlorambucil. And then I talked a little bit about acalabrutinib and ibrutinib. So ibrutinib was the 1st generation drug. What we wanted to see is, are these drugs equivalent? Does one work better than the other? This was a study that was done in relapse refractory CLL, but probably can be extrapolated. Sort of those results are important for our frontline treated patients as well. And what we see is that the outcomes, these 2 lines, are exactly the same, which means that patients respond exactly the same. But what we see here is that there's more cardiac side effects with ibrutinib, which is in this blue line, compared with acalabrutinib. And so looking at this curve on the right, we're really seeing that more patients are having incidents of atrial fibrillation, whether they have a history of atrial fibrillation or not, with ibrutinib compared to acalabrutinib. And the way that I look at this is that acalabrutinib has the same efficacy as ibrutinib, but has a better safety profile. So it's better from a cardiac standpoint. There's fewer hypertension events. And so those to me are very important when I think about CLL patients who are going to be on a BTK inhibitor continuously and sort of trying to minimize the potential for toxicity long term. Now, next we'll talk about zanubrutinib. So zanubrutinib, again, was FDA approved for frontline treatment of CLL based off of this study. This was comparing zanubrutinib to chemoimmunotherapy with bendamustine rituximab. And as I said before, I don't think that this is a treatment option for patients in the United States with CLL. So this curve doesn't really do much for me. But what we can see is that at 2 years, only 15% of patients have progression of their CLL on zanubrutinib, which I think is great. It means that patients are going to have these long durations of responses to zanubrutinib in the frontline setting. And similarly to what we saw with ibrutinib, similar to what we saw with acalabrutinib, the question is always, well, we have all these BTK inhibitors. How do we choose between the 2 of them? So this study looked at comparing zanubrutinib to ibrutinib, and what we see is actually there's better responses with zanubrutinib compared to ibrutinib. And again, similarly lower rates of atrial fibrillation and flutter, so lower rates of cardiac events. Now, in this study, there were similar rates of high blood pressure or hypertension, which was actually, I think we all thought a little bit surprising. So again, that's one of the key differences and something to talk with your doctor about when we're sort of deciding between covalent BTK inhibitors is which side effect profile works best for me. Now, I think that this brings up the point that all of our BTK inhibitors have very specific side effect profile that we've seen across all of them. So there are cardiac side effects, whether it's atrial fibrillation. You can see ventricular arrhythmias, though this is very rare with acalabrutinib and zanubrutinib, but has been reported, as well as high blood pressure or hypertension. And that can be new hypertension or worsening of existing hypertension. There is a risk of bleeding. All of these act as sort of antiplatelet agents. So our platelets are important for blood clotting. And when our platelets don't come together exactly the way they're supposed to, it just takes a little bit longer to stop bleeding, and it also makes it easier to bruise. That's important from a procedure standpoint, but also is sort of why everybody always asks at all of these visits, are you having any bruising? Very rarely you can have major bleeding, so bleeding that can cause you to be in the hospital. And I think it's important to know that going in, particularly if you are on a blood thinner, although it is safe to continue blood thinners and be on acalabrutinib, zanubrutinib, or ibrutinib. One of the toxicities that I think is really important because it does affect quality of life are joint pains and muscle aches and muscle spasms. These are things that are really challenging to manage from a clinical standpoint, and you may need to start or stop zanubrutinib, ibrutinib, or acalabrutinib if these happen. But again, something to know about going into treatment, and I think it's one of these side effects that really is important because it can be very, very challenging if your hands are cramping all the time to be able to do your activities of daily living. And finally, diarrhea, I think, is another one that can happen. Most of the time, it's time limited, meaning it gets better over time, but it can be very challenging at the start, especially if you have pretty severe diarrhea, like 4 to 5 to 8 episodes a day. So again, something to know about, to talk with your doctor about, particularly if you have any underlying GI illness. And all of our BTK inhibitors are associated with the risk of infections. I think it's always challenging to figure out if these are related to the underlying CLL, the drugs themselves, but something to talk to your doctor about and to ask, are there any medications that I should be taking with my BTK inhibitor in order to prevent infections for me? So I said that we've now looked at comparing acalabrutinib to ibrutinib and zanubrutinib to ibrutinib. These two will never be compared head to each other in a clinical trial. And so we're all trying to figure out, are there patients that are better for one or the other? I think the key takeaway for me, and I get asked this a lot, is I think both work well, and I still prescribe both in my own clinical practice. The nice thing about zanubrutinib is that if you don't want to take a pill twice a day, you can take it once a day. The challenge is that there are higher rates of hypertension when I think about how to distinguish the two. And acalabrutinib is also associated with headaches, usually within the first month. Often they get better with caffeine. And the mechanism is still sort of under study. We're not 100% sure. Seems to happen more frequently in the United States compared to Europe. I think probably because their coffee is stronger. We all know a good Italian espresso can make any day better. So next we'll talk a little bit about fixed duration combinations. So this is 6-year follow-up from the CLL14 trial. CLL14 was the study that got venetoclax and obinutuzumab approved. That's in the blue line. In the red line is that chlorambucil-obinutuzumab that we don't really use in the United States anymore. And the way that this was studied was that patients received 1 year of treatment with venetoclax obinutuzumab, and then they stopped. And then these patients were followed to see if and when their CLL progressed or came back. And this is really progressing off of treatment. So what we're seeing is that at 6 years, still 50% of patients haven't had their CLL progress, which means that the majority of patients are off of treatment for 5 years without having their CLL come back. And I think that that's really amazing and important. There are some caveats, which we'll talk a little bit about in the next section about high-risk CLL, but I will say we know that there are differences in the disease biology for patients whose CLL is either IGHV mutated or unmutated. And even here, even this is a little bit more similar to chemoimmunotherapy, although the responses are still so much better with our newer agents, that patients that have CLL that's IGHV mutated have longer progression-free survives, have longer time off treatment and better responses oftentimes to fixed duration treatment than if there's IGHV is and then if their CLL is IGHV unmutated. That doesn't mean that this isn't an option for you, but I do think it's something to talk about with your doctor specifically of, can you give me a ballpark idea of how long I could be off of treatment and how many years I might get, how many months to years or really years could I get off of therapy? So side effects of venetoclax obinutuzumab. So again, sort of thinking about this from a patient perspective, what are the things that could happen if you use this regimen? I always tell patients, almost every single patient I've seen has a reaction to obinutuzumab, this infusion reaction. It can be things like my lips are tingling, I feel hot and flushed, I feel short of breath, my heart is racing, or even as severe as my blood pressure drops. When we give obinutuzumab, we give a test dose, sort of like a baby dose the first day, and then the rest the second day because of those infusion reactions, and it's given very slowly. But I do warn patients that nearly all patients do have some version of an infusion reaction, especially for frontline treatment of CLL. The reason being is that oftentimes your white count is high, you may have a lot of lymph nodes, your spleen may be enlarged, and so there's a lot of CLL in your system to react with the obinutuzumab. The one that I think we talk a lot about is tumor lysis syndrome. And so that is basically what happens when we kill off CLL cells so quickly that whatever is inside of them, your kidneys can't keep up with filtering out all of the junk that's inside of them, all the electrolytes. And that can lead to things like arrhythmias and seizures and kidney failure. And so that's why we worry so much about it. It's much more rare to have happen now with venetoclax, with the combination of venetoclax and obinutuzumab, but it's why we give venetoclax as a ramp up. Other side effects include low blood counts, whether it's a low white blood cell count with neutropenia, anemia, thrombocytopenia, or risk of infections. And just thinking about this from a practical consideration, so fixed duration treatment is amazing, and I love it. I love it for many of my patients. But there's a lot that goes into being able to stop treatment, and it really is sort of front loading a fair amount of effort and time in clinic and time with your doctor early on. So obinutuzumab is given 2 days in a row, then it's given weekly for 2 weeks, and then it's given monthly. The venetoclax ramp up happens weekly for 5 weeks in a row. There's lab work that needs to be done beforehand and after, sometimes 1 or 2 lab draws, depending on where you are in your ramp up, in order to ensure there is no tumor lysis syndrome. And for patients who are at a very high risk for tumor lysis syndrome, sometimes we even manage a couple of those step-ups in the hospital. So again, this is another practical consideration for thinking about, is this the regimen that's right for me? Again, the trade-off, and I look at this as sort of your time involved in your treatment as an investment, whether you're going to invest a lot of time up front and then have and then not be on treatment versus sort of a slower investment of time over time with continuous treatment. So one of the things that often comes up and we often talk about, and I think probably doesn't get spoken about enough, is, well, I have some of these higher risk markers. My CLL has some of these higher risk markers. What's the right treatment for me? The answer is that I don't think that we know. People have a lot of very, very specific feelings about how to treat deletion 17p or TP53 mutated CLL. These are the outcomes for patients who were treated on CLL14. It was very few number of patients, only 25. So not a lot of patients have actually received this in the frontline setting on a clinical trial. But we see that, the patients who have a deletion 17p or TP53 mutation, they do have a tendency to have their CLL relapse sooner than if their CLL didn't have those mutations. Now, does that mean that you can't get fixed duration treatment? No, but it may mean that you're not going to get your CLL, your time off treatment may not be as long. And knowing that going into treatment and understanding that there's some different disease biology at play, I think is important when deciding what treatment is right for you. And I think the reason people feel so strongly about this is that the first indication for frontline treatment for ibrutinib actually was for patients with deletion 7 whose CLL had a deletion 17p or TP53 mutation. And that was actually one of the most landmark changes in CLL treatment. Once we knew that these patients responded so well, we stopped giving them chemotherapy in clinical trials immediately, because patients were living so much longer on BTK inhibitors. The majority of patients at 10 years were still alive, where before they weren't. And I think that that's a really remarkable thing, and why BTK inhibitors have become such a cornerstone of our treatment. And this is just some updated data. So zanubrutinib has a cohort of deletion 17p of patients whose CLL had deletion 17p. This is actually one of the largest cohorts on a clinical study of patients whose CLL had deletion 17p. And so we're seeing outstanding results from this. And so it'll be great to see how patients do over time and how they tolerate zanubrutinib continuously, as we sort of continue to try and figure out for patients whose CLL has higher risk mutations, what's the correct regimen. Similarly, again, for patients whose CLL has a deletion 17p or a TP53 mutation, treatment with an acalabrutinib containing regimen is correct. They do patients with that, patients' outcomes are better. We were hopeful to see that maybe the addition of adding another agent, adding the obinutuzumab in this patient group whose CLL has a high risk feature, would improve outcomes, but it didn't. And so really for patients whose CLL has a deletion 17p or TP53, if I'm going to give acalabrutinib, I recommend it just as a single agent. So what are some of the other factors to consider when thinking about treatment? So we talked about patient preference. I think that that's the most important thing. This is, every CLL patient is their own person. Their disease is, every CLL patient's disease behaves in its own way. And really the question is, how does CLL treatment fit into your life? Other things that we do take into account are, we can take into account age, fitness. So do we think that you'll be able to tolerate some of the medications and the frequent visits, if that works for your schedule? Again, we talked a little bit about genetics, and so ensuring that these tests have been done, TP53 mutation, deletion 17p, the IGHV mutation, I think are so important that you know what your genetics are going in, so you can so you and your doctor can have a conversation about how you might respond, how your CLL might respond to treatment. Karyotype, again, can be a useful marker as well. Thinking about renal function, so if your kidney function isn't perfect, maybe venetoclax may not be the right thing for you from a tumor lysis risk, or maybe you want to do it, but we have to be a little bit more cautious and do some more monitoring. Whether or not you have any cardiac comorbidities, so do you already have atrial fibrillation? Do you have a history of any ventricular arrhythmias? Do you have high blood pressure at the start of treatment? Just so that we can monitor those very closely for those side effects. Maybe work specifically with your cardiologist, or send you to a specific cardiologist that specializes in taking care of patients who also have oncologic issues, someone called a cardio-oncologist. And then what are the other medications that you're on? So our medications can interact with other things, and so there's differences in dosing, and knowing what those are is super important. And let's say you're on an antiplatelet agent and an anticoagulation. Should we be continuing both of those? Can we stop one or the other before we start, let's say, a BTK inhibitor, just so that we're sort of understanding what your bleeding risk could be in the setting of starting a new treatment for CLL. So my quick concluding thoughts, because I want to get to questions, because I'm so sorry we started late. There are many options for frontline treatment of CLL, including covalent BTK inhibitors and fixed duration venetoclax-based regimens. The safety of second generation covalent BTK inhibitors has been demonstrated across trial, and these are the drugs that I reach for frequently if we have decided that continuous BTK inhibitor therapy is the treatment we're going to use. Patient preference over which avenue we choose is the most important consideration. And the first line therapy options would be tailored to you and your CLL and your preferences. And with that, I thank everyone for your attention and for hanging out while we figured out why my computer did not work and shared my screen. I just want to acknowledge our patients, as well as my mentors and the team at Robert Wood at Rutgers Cancer Institute, and my former team at the CLL Research and Treatment Program over at Northwell. And I'm ready to take any questions.
All right, so thank you for that great presentation. I think you did a fantastic job once we were able to figure out the tech stuff. So, like Dr. Red said, now it's time for questions. I know that we have a few in the chat, but just as a reminder, you can type those questions in the chat, or you can unmute yourself and ask that question. Um, so we do have this time set aside, so don't be bashful. We want you to get as much out of this as you can. If you need to hop off prior to the completion of our Q&A, we understand, but you'll still have access to that post-event survey when you leave. So let's see. Temp says, what does it mean if I'm 20% 17p deleted?
That's a great question. So I think it's important to know that not every CLL cell in your body is going to look the same. There are some differences. We call them, there's differences in what we call clones. And so when we looked at this sort of in the lab, all the CLL cells probably start off from one specific cell that picks up a mutation, but it's evolutionary, right? Just like, you know, we all came from like whales, and some people we managed to walk, and now we have apes, and there's different evolutionary factors within mammals and birds and everything else. There's probably different evolutionary there's different strains on different clones of CLL that sort of allow other clones to kind of come out, having to do with different mutations and things like that. For all intensive purposes, if anything is reported out as deletion 17p positive, I would put that into the category of a deletion 17p. But again, it does bring to the point that perhaps there are still going to be differences between patients that have deletion 17p and TP53 mutations. Again, when we sort of clump everybody together, we sort of see the middle ground of how patients respond, how patients CLL responds to therapy. But that's sort of just a conglomerate. Really, the only thing that matters is the N of 1, how you and your CLL respond to treatment.
All right, next up we have Sarah. Do you think there will come a time when you'll treat people sooner if you're heading towards treatment, but before you get full-blown symptoms?
Oh, excellent question. So I think that this is one that comes up pretty frequently now. So we used to really delay treatment until patients had a lot of symptoms because it was chemotherapy. And we knew once we started, we were going to just continue to do chemotherapy over and over and over again. And the time that you would actually get off of treatment would be shorter each time because we're using the same thing. We didn't have as many options as we do now. I think that that's a really personalized question at this point, and I think the question is really has to do with like what are the symptoms and what are the full-blown symptoms that you're trying to avoid. And sometimes I think one of the most common and challenging things is fatigue and figuring out if fatigue will get better if we treat CLL. I think some of the symptoms I often treat for lymph nodes that, are bothersome, they go up and down, but perhaps are more up than down and more bothersome more days out of the week than they were previously. Night sweats, I find, are one of the ones that I often will start treatment for because sweating through your clothing every night is just uncomfortable, particularly if it's starting to be more than once a month, every week, every other day. But I think that that's a great question. There are now also studies ongoing for patients with high-risk CLL of being treated right at diagnosis versus at the time of a sort of indication for treatment like we talked about with venetoclax obinutuzumab. It's a randomized study that's open at a lot of academic medical centers and some community centers as well, which could potentially be a great treatment option if anyone on this call or anybody in general who's listening to this ends up being eligible, but something to ask your doctor about.
All right, next up. I'm a 76-year-old female, recently diagnosed in 2024. I'm unmutated. My hemoglobin is 9.7 currently. I'm only trisomy 12 with a score of 76 on the IWCLL. I favor venetoclax obinutuzumab, but my local heme onc wants to wants me to get a few weeks of steroids before beginning. Do you have any thoughts on this? And would I be better with a BTKI?
So without having sort of your full medical record, it would be very hard to give you sort of medical advice on this. Steroids are really helpful if, let's say, there's an autoimmune component to your anemia. I just don't know that or not. I think having a long conversation about what are the pros and cons of venetoclax obinutuzumab versus a continuous BTK inhibitor are important to have. And I would ask them why they wanted to do a trial of steroids specifically. What would the indication be?
All right. Is clonoSEQ used to monitor? And if so, is being tested with a blood draw versus bone marrow biopsy better for monitoring?
Great question. So outside of clinical trials, clonoSEQ often is not used. I didn't show this, although I recently we recently did a talk on undetectable measurable residual disease. But for continuous BTK inhibitors, we know that sort of we get great control of the disease of CLL, but very few complete response rates. And that's okay because patients do very well for a very long time on BTK inhibitors. So for those patients, I do not check clonoSEQ. For patients that are going to get venetoclax obinutuzumab, I often will check it, but not every office has clonoSEQ available. It's a specialized test. It has its own kit. It's a send out test. So something to discuss with your doctor, and it's not standard of care currently. And I don't know what insurance reimbursement is like across states. So I usually figure it out on my end before testing patient's blood or bone marrow for it. I do peripheral blood. There's what we call concordance between peripheral blood and bone marrow. The tests basically look very similar in terms of results.
And is it the same if I have TP53 deletion versus mutation?
Great question. There's probably some biological differences between so deletion 17p, we have chromosomes we basically get two chromosomes, one from mom, one from dad, or one from each parent. Chromosomes have sort of a top part and a bottom part. What deletion 17p means is that either one or both are missing an arm of your chromosome. And so all of that genetic material is gone. So that's the sort of deletion portion of deletion 17p. TP53 mutation means that the chromosome is still there in its entirety, but somewhere in here where TP53, which is a gene, there's a mutation within the genetic code there. So it is a little bit different. We know both, but the reason being that both are important is that they're both, if you lose deletion 17p, if that's one of the markers, that TP53 just isn't there at all. Whereas if it's mutated, it's there, it's just not functioning the way that it was intended to. That can have different outcomes, and also can have different outcomes depending on whether or not your CLL has deletion 17p and a TP53 mutation, whether or not there's two TP53 mutations. So it gets a little complicated. And again, that would be something in your own reports to discuss with your doctor specifically. But that's sort of the overarching portion of that.
All right. How does a patient's age and overall health impact the treatment options for CLL? And how can a patient best communicate their treatment preferences or concerns with their healthcare team?
I think that this is hard because it can be challenging to walk into a doctor's office and advocate for yourself. I think the best thing to do is to try and ask questions about what treatments are and then see how to engage in the way of saying, well, my life is this. So let's say traveling is very important or work is very important and you can't take a lot of time off. That's something to definitely discuss with your doctor. If getting to and from the doctor's office is challenging for whatever reason, another thing to bring up, because I do think that being able to get to and from if you're starting treatment does impact how I would steer you towards one treatment versus another and how that would fit into your lifestyle.
So, and then this is probably going to be the last question, and it's actually addition to a question that we touched on earlier. But Um, Digging further into my previous question, are steroids used to reduce the chance of allergic reaction to infusions ever? Um, I have quite a few bulky nodes, mostly in my abdomen and chest. I've never heard about I've never heard about these steroids being used in this way, but my hemonc is very persistent about it.
Oh, I actually do this all the time. So this is actually a very normal thing to do. So prednisone, dexamethasone, methylprednisolone, all of these steroids actually have anti-lymphoma properties. So what they do is they actually kill off lymphocytes specifically. You'll see your white blood cell count can go up when you're on steroids, but that is actually lowers your lymphocyte count. And by doing that, you sort of start to debulk some of the CLL nodes and everything else that can help to decrease the risk of infusion reactions. They're actually given across the board as part of the pre-medications that are given to prevent infusion reactions for any monoclonal antibody, obinutuzumab, rituximab, ofatumumab across the board. But doing it sort of for a couple of days beforehand can decrease the risk further, particularly if you do have bulky nodes. The other thing is that steroids have anti-inflammatory properties, so you have a little bit of a less of a robust sort of cytokine immune response, which can decrease the rates of fevers and things like that too. So thank you for clarifying that. This is complete. I do this in my own clinical practice as well, and I think it's a great way to sort of prevent prevent more severe infusion reactions, which can be very scary and can land you in the ER.
Mhm. All right, we're getting short on time, so I'm gonna wrap up our Q&A session here. So I just wanted to thank you again, Dr. Rhodes. That was wonderful. So before we go, I want to highlight a feature of CureHub, and this is going to be the treatment options and clinical trial finder. Once you've connected your medical records in HealthTree CureHub, you can start exploring a wealth of information about ongoing clinical trials and treatment options that are available for your blood cancer. This information can help you make informed decisions and prompt important conversations with your doctor. On the screen, I have the link for the sign up for HealthTree Care Hub, along with the email address of our amazing patient navigators who are able to help you create an account and connect your records today. I'll also include information about how to enroll in HealthTree Care Hub in our follow-up email, so be on the lookout for that. And then I did want to highlight the next event that I have coming up for our CLL community. And this one's going to be what chronic lymphocytic leukemia patients should know about Richter syndrome. And this is going to be with Dr. Aaron Perry. And that's going to be on Wednesday, November 20th. All right. And then as you leave today, we would appreciate if you would take 2 to 3 minutes to fill out that brief survey that I was talking about. We really appreciate that feedback. It helps us put on wonderful events about the topics the community really cares about. So it really helps me out when you do take the time to do that. Um, and with that, I just want to say thank you to everyone for helping us build the CLL community. A special thank you to Dr. Rhodes for that great presentation today and answering questions. You did a wonderful job. And with that, I hope everyone has a great rest of your day. My email is on the screen, so feel free to email me if you have any questions. All right. Have a good day. And yeah, thank you again, Dr. Rhodes. That was great.
Oh, good. I hope it was
Yeah,
helpful.
yeah.
Sorry about
I'll
the
send you a
sorry about the technical issue. I don't know what's going on with Zoom.
it. It's one of those technology is so wonderful, but you just never know what's going to happen with it. So it's not the first time something like this has happened. I'm sure it won't be the last. So don't worry too much about it. I'll send you a follow-up email here a little bit later this afternoon. And then I can also either get you in contact with Jay, he's our research director, um, and he will be able to give you a little bit more information about that. But yeah, I'll send you a follow-up email, and then we can keep in touch about finding time to do a podcast, because that's something that I absolutely would love to do with you.
Yeah,
I think you did a
it'd be fun.
fantastic job explaining everything.
Oh,
So
great. Thank you. I try. I try.
yeah, so yeah, I'll be in touch with you. So
Awesome.
awesome. Thank you again and have a great
Thanks
day.
so much, Dalton. Thank you so much for the
Yep.
opportunity. Hope this was good.
Oh, it's wonderful. Thanks.
Bye.
Bye.